What's up, beautiful people? Another day, not another study. What I wanted to talk about today is something that is a miscommunication between providers, physicians, people who prescribe interventions, whether that's surgery or medications, and patients. And that is about safety. And what do we mean when we say something is safe? Because I think it has a different meaning to physicians than it does to patients. And so we're going to bridge that gap. And I think this is extraordinarily important because I believe in informed consent. I believe it is a patient's right to choose a treatment that they believe is best for them, but they must be adequately informed about the costs, the benefits, and the risks. And I think that for a lot of medications and even surgeries on the conventional side, and then supplements by the healthcare grifters, that the benefits are overstated, whereas the risks are understated or minimized. I've seen people talk about how supplements have no risks, no side effects. That's definitely not true whatsoever. Supplements are powerful, can be powerful, and they work by the same principles of pharmacology that medicine works by, that drugs work by, that pharmaceutical products work by. So they can have side effects, and sometimes those side effects can be quite severe. But anyway, let's go back to this original concept of safety, because I think that when I tell a patient something is safe, they're taking it as, oh, this will not harm me, right? But that's not what safety means as far as a physician or a healthcare provider talking about safety. What we mean when we say something is safe is that it has a beneficial safety profile. And what I mean by that is when you do that cost benefit risk analysis that you should do with any treatment, whether that is supplement, medication, lifestyle, whatever, that the benefits far outweigh the risks. And not only do we look at the benefits outweigh the risk, we look at what degree of benefit. Does this just benefit their primary condition? Does it have benefits to secondary conditions? Like if someone's overweight and I prescribe exercise and they have elevated blood pressure, exercise is going to be beneficial for their blood pressure and for them to maintain a healthy body weight, right? We also have to look at this from the risk perspective as well. What is the degree of risk? If the risks are, oh, you might get a slight nosebleed and maybe a tummy ache, that's different than if the risk is, oh, it might cause intestinal obstruction, or it might worsen heart disease or cause a stroke, or you might have an allergic reaction and die, right? There's a varying degree of risk. And so that's what we have to evaluate when we evaluate the safety profile. We have to look at what are the risks, what are the absolute values of the risk, meaning does it happen in 10% of people? Does it happen in 20% of people? And then look at the severity of that as well. If you have a really severe risk, but it only happens in 1 out of a million people, then odds are you're not going to experience that adverse effect. Now, that doesn't mean that someone won't experience that adverse event. And so when we look at these things from a more scientific perspective, we're looking at a few numbers here. And one of the things that I've talked about, that I'm meticulous about, that I evaluate is the absolute risk reduction, number needed to treat, and number needed to harm. Because I think we do a poor job of telling people that things like surgery, things like medications, even supplements are going to harm some people, and that there are some people that they are not going to help. And one of the things I try to look at is, how can I better predict, is this someone that's going to be helped? Is this someone that's going to be hurt by pharmacology, by clinical experience, and by the studies? If they do that type of subgroup analysis, looking at, well, who's most likely to benefit in this population that we studied and who's most likely to be harmed. So let's go back to absolute risk reduction. This is a very, very important part for knowing clinical efficacy of a treatment. So we're going to use some numbers here, some made up numbers. Let's say I have an intervention X and I'm comparing it to placebo Y, and I'm doing this in 100 people. right, in each group. 34 people in the placebo group experience some type of outcome, whatever I'm studying. 17 people in the intervention group experience it. So in that scenario, my absolute risk reduction is going to be at 34% compared to 17%. So it's going to be 17% absolute risk reduction. And so when people hear X treatment reduces Y by Z%, in our minds, we think absolute risk reduction. But what's often reported is relative risk. Relative risk is a risk ratio. So in that example I just mentioned, the absolute risk reduction is 17%. So you have 34%, 17%, 34 minus 17, 17, pretty simple. But the absolute risk reduction would be 50%. So if I'm a drug manufacturer, I'm going to tell you there's a 50% risk reduction. It's relative risk. And this is something that we've talked about before. It's something that I think you should absolutely have to tell people the absolute risk reduction and not the relative risk. Relative risk can be very misleading because I don't think that's how most patients think about these things when they hear these numbers. And then I talked about another very important thing that we can calculate from the absolute risk reduction. So the number needed to treat is a very, very important number. Earlier in this conversation, we talked about how not all treatments that we prescribe will help all of the people we prescribe it to. So when we look at that absolute risk reduction, we can calculate the number needed to treat. How many people do I need to treat with X surgery or X medication or X supplement to prevent one of the outcomes that I'm looking for? Let's say it's stroke or heart attack, right? In that previous example I gave, the absolute risk reduction was 17%. So if the absolute risk reduction is 17%, I need to treat 5.88 or 6 people to prevent one heart attack or stroke, right? Now, that's actually a pretty good number. You know, if you're looking at a population level, I have to treat 6 people to prevent one instance, and I'm treating millions of people. That's a lot of lives saved, right? But you don't know if you're the one or if you're the other 5 people that it's not going to have that outcome prevented. And that's why I think we tend to overestimate, meaning that when patients are put on these drugs, they think that they're always going to benefit. And I've seen this where people come back to me and say, I don't understand why this outcome happened. I'm taking my drugs like the doctor told me. Why did this happen? And I think we do a poor job of explaining these scenarios, even though a lot of physicians and providers know them. Some don't. I don't know. I've never really talked to someone who calculates number needed to treat when they look at drug studies. The other end of that is number needed to harm. I have to be acutely aware of that when I prescribe a medication or put people on a supplement or recommend that someone gets a surgery, somebody can be harmed from that. And then looking at the data, there are people who are harmed from these interventions. We have to be aware of that. And so one of the things I'll look at when it comes to drug trials is the number needed to harm. And it's calculated basically the same way the number needed to treat is calculated. You look at the absolute risk of a side effect or adverse effect, take that number, 1 divided by that number, and that's the number needed to harm. And you can look at that for adverse effects total, like how many patients had adverse effects total, or you can look at it per adverse effect. And so that's what we look at when we're looking at the safety profile. We're looking at cost, we're looking at benefit, we're looking at risk. And so when we say something is safe, ideally it has low cost, and typically we're thinking financial cost. But if this is something like prescribing an exercise intervention, the cost could be time, right? Then we're looking at benefit. So the ideal scenario is something is low cost, high benefit, low risk. And a lot of times why we like lifestyle interventions is because they can be low cost or no cost, high benefit, low risk. And then different medications and supplements and surgeries have different risk profiles, and the profile may be different for you as compared to your neighbor and compared to their neighbor, depending on lots of different demographic information. And so that's why it's really difficult to just come out and say, oh, something is safe, because it may have a great safety profile for someone and a terrible safety profile for the person next to them. And I think we need to do a better job of communicating this stuff. And so that's why I wanted to come on here and shoot this rather longer video. It's something that's been rattling around in my head for a while. I'm going to try to do this more often, especially in March when I free up some more time, especially as we get into starting to see patients in direct primary care. It's something that I want to be able to provide. Of course, all my educational stuff is free of charge. So thanks for tuning in. I appreciate your time. I hope you have a blessed day.